Greetings. I'm Dr. Robert Pudenz, a Pasadena neurosurgeon, and Dr. Eldon Foltz and I have been asked by the AANS to discuss hydrocephalus. We will be discussing this from several points of view: the history of the surgical treatment of hydrocephalus, its pathophysiology, its treatment and complications, and we'll wind up with some new concepts in the management of the problem. I would like now to have Dr. Foltz talk to us about his educational background.
I grew up in Michigan, and I went to Michigan State University and then to the University of Michigan for my medical education, where I also interned. It came under the influence of some very adroit teachers who I recognize now had quite a great influence on my full program of my life. From the University of Michigan, I interned there, went away to the Navy, came back to the University of Michigan, came under the influence of Elizabeth Crosby and neuroanatomy, spent some time as a graduate student with her in neuroanatomy, ended up then as a first resident in the neurosurgical service at Dartmouth Medical School. From there to the University of Louisville. Then I went far to the northwest in the country with Arthur Ward at the University of Washington, where I completed a postdoctorate fellowship from the National Institutes of Mental Health, and progressed then over a period of a number of years until 1969 in the academic arena. I left the University of Washington in 1969 to the University of California at Irvine, where I have been sent since that time. I consider that my training is still incomplete, and whenever anybody asks me where I took my training, I say that I'm still in training and I'm considered a resident 45. Dr. Pudenz, maybe you could tell us about your educational background.
I was born in Cincinnati, Ohio, had my pre-medical education at the University of Dayton and the University of Cincinnati, and my medical education at Duke University. Following my graduation, I had an externship at the National Hospital, Queen Square in London, England, where I did my neurology. Following this, I had a year of general surgery back at Duke Hospital, and then, fortunately, went to Montreal for my neurosurgical training. I have never regretted one moment having gone to Montreal, because my teachers there, Dr. Penfield, Dr. Cohn, and Dr. Elvidge, from the very beginning inspired us to do research, and this has proved to be a very valuable part of my life. In 1942, I joined the U.S. Navy and spent the years of the war mostly at the National Naval Medical Center in Bethesda. And there I met my associate, Dr. Hunter Sheldon, with whom I've been in practice now for 48 years. We've been asked to mention the people who have been influential in our careers. Certainly, I would defer to my teachers in Montreal, Dr. Penfield, Dr. Cohn, and Dr. Elvidge. I'm very grateful to Dr. Winchell Wink Craig, who was our captain and later the first reserve admiral in the U.S. Navy, and to my meeting Hunter Sheldon, who has been a great influence on my life. I am going to be responsible in this presentation for the historical development of the surgical treatment of hydrocephalus, and will refer to experimental work that we did on hydrocephalus at the Huntington Hospital and the Huntington Medical Research Institutes in Pasadena. I would like now to show some slides. What I shall present has been reported in 1981 in the journal Surgical Neurology, at which time Dr. Paul Busey, who was editor of this journal at the time, asked me to write a paper on the history of the surgical treatment of hydrocephalus. I think this is an important thing to present to our younger neurosurgical colleagues because, as you will see, it shows the many techniques that have been used in order to treat this very difficult problem. For example, here in this slide, we have cauterization of the choroid plexus. Now, the choroid plexus was originally extirpated by the late Walter Dandy of Johns Hopkins. Unfortunately, it was a formidable procedure, and he did not continue this work. Now, our techniques for cauterizing the choroid plexus are much more sophisticated with much better instrumentation. To my knowledge, the first person who treated the choroid plexus by cauterization with an endoscope was the late Dr. Jason Mixter of Boston. We have had many procedures involving shunting of cerebrospinal fluid into the structures of the head. I will not attempt, because of the limitation of time, to mention all of the individuals who were involved in these techniques. But for example, here you see shunting into the mastoid antrum, which was introduced by Dr. William Nozick of Cleveland. Here are techniques shunting into the subdural space, techniques shunting into the sagittal sinus, techniques shunting into the pericallosal cisterns, and again I show third ventriculostomy. Then we have other procedures involving shunting into structures of the head and neck. For example, a shunt is a classical ventriculocysternostomy, which is a procedure that is still in use and was introduced by Arne Torkelson in 1939. Here we have techniques of shunting from the third ventricle into the cisterna ambiens, shunting from the third ventricle into the fourth ventricle, so-called interventricular shunting. And then we have the shunts from the lateral ventricle into the internal jugular vein. And I'll mention more about this later. This is a technique of ventriculocysternostomy, the Torkelson procedure, which I alluded to previously. In Torkelson's original procedure, the end of the shunt tube was placed in the cisterna magna, and later this was modified by Dr. Donald Mattson of Boston in shunting into the upper cervical spine, placing the shunt tube anterior to the dentate ligaments. Another diagram showing third ventriculostomy, a procedure that is gaining more and more popularity in recent times. I come back now to the technique that we developed in Pasadena. And apropos of the shunt from the lateral ventricle into the left or right atrium of the heart, a procedure known as VA shunting, ventricular atrial shunting, I might point out that, to my knowledge, the first valve shunt system was reported in 1950 by Drs. Frank Nelson and Eugene Spitz, and they had a homemade valve using two steel balls for control of fluid flow that went into the internal jugular vein. The ventricular atrial shunt, in contrast, placed the end of the shunt tube in the atrium of the heart rather than the internal jugular vein, and I'll discuss this more later when I talk about our research program in the early 1950s in Pasadena. Now, other shunt systems that have been used, for example, as you see here in D, this is a technique that Kempe and his colleagues used, shunting into the thoracic duct, in other words, into the lymphatic system. And here you have shunting into the pleura a procedure that was originally done by Hyla, but was popularized in more recent times by Dr. Joseph Ransohoff of New York. Another diagram of the ventricular atrial shunt from the lateral ventricle to a valve flushing device into the atrium. Then we have the various types of shunting into peritoneal structures. In some peritoneal shunting techniques, the end of the tube was placed above the dome of the liver to keep it away from the greater omentum and the loops of bowel which would invest it and obstruct it. Also, we had shunts into the gallbladder. We had shunts into the stomach. We had shunts into the small bowel, ileoantectropy. And then we had shunts into the fallopian tube of the female. In this diagram, we see shunting from the lumbar subarachnoid space into the omental bursa. This is a more formidable procedure than ventricular atrial shunting, but in my personal experience with 5 patients has been a very satisfactory procedure, and I think it should be re-explored. Then we have the shunting from the lateral ventricle into the ureter, or from the lumbar subarachnoid space into the ureter, so that the cerebrospinal fluid escape with the urine. These procedures were also done in the early part of the century by Hyla, but were popularized by Donald Madsen in the post-World War II era. This essentially shows what I showed in the previous slide, shunting from the ventricle or the subarachnoid space into the ureter. Then a procedure that is still commonly done and will be discussed by Dr. Foltz later is shunting from the lumbar subarachnoid space into the peritoneum, a procedure which is particularly valuable in communicating hydrocephalus.
Bob, that's a very concise review of some rather interesting approaches to hydrocephalus. It's put a lot of work into a very short time period. I know you did some clinical trials and did some experimental work on this topic too, and possibly you should tell us that.
In 1952, my colleagues and I at the Huntington Medical Research Institutes in Pasadena decided to re-explore the feasibility of shunting cerebrospinal fluid back into the circulation. This has a fantastic history inasmuch as this technique was proposed in 1898 by the German Enderlin, and actually in 1907, another German surgeon by the name of Peyer attempted to shunt from the lateral ventricle into the sagittal sinus, and later used a formalin-fixed anterior and posterior tibial arteries of the dog to shunt from the lateral ventricle into the internal jugular vein. Following this, as the years passed, there were attempts by others to shunt into the circulation, but then we come to the paper of Frank Nelson and Eugene Spitz, who shunted from the lateral ventricle into the internal jugular vein, as I mentioned previously. We learned later from Dr. Nelson that this shunt occluded eventually, but despite that, the patient apparently had a communicating hydrocephalus, and he needed only one shunt and progressed very satisfactorily. So in 1952, in Pasadena, we carried out a series of experiments to study the feasibility of shunting into the circulation. And this study had many facets to it. For example, we started out evaluating techniques to produce hydrocephalus in animals. And here in this slide, you will see varying degrees of hydrocephalus which we were able to produce by injecting kaolin into the cisterna magna. For example, here we have a normal dog brain, and as we proceed from left to right, we see the rather massive hydrocephalus which we were able to obtain. it was very interesting that in this study we found two things. One, that we had much greater hydrocephalus in animals that were immature. In other words, hydrocephalus similar to that which we experience in human infants. So that here, for example, on the extreme right is rather massive hydrocephalus, which we were able to produce in puppies in contrast to adult animals. Another cross-section of the type of hydrocephalus which we were able to produce. Then we found that if we wanted to get more marked ventriculomegaly or ventricular enlargement in our animals, if we did a linear craniectomy on them, in other words, opened up the skull of the adult animal, we were able to obtain this sort of enlargement. Here, for example, is our animal that we have rendered hydrocephalic, and here's the control dog brain for comparison of size. Then here is the same brains in cross-section showing the type of hydrocephalus you can get by opening up the skull. Now, that was one phase of our problem, to have an experimental animal with hydrocephalus. But then there were other problems. Up to the time we did our studies, various types of tubings had been used in shunting, primarily polyethylene, which had the disadvantage of kinking and being rather difficult to handle because of its physical properties. We also had the various types of rubber, Portex and latex. And finally, we, through our help of our colleagues at Dow Corning in Midland, Michigan, we obtained silicone tubing. And silicone tubing proved to be the type of tubing that was not only best for our studies from the physical and mechanical points of view, but also produced very little tissue reaction. Here, for example, is a cross-section of the area occupied by a silicone tube in the white matter of the brain. Then we also had the problem of what type of valve system should we use. And in this study, we had the help of many people, colleagues at the California Institute of Technology and other mechanical and biomedical engineers. And we came out with these two types of valves. In our original shunt, we used a valve, a miter type of valve made of Teflon. But then in all our later cases, we used our flow control was via slits in the end of the tube. And I have some examples of these early shunt tubes here with me, and I will show them in a moment. I'd like to comment on Teflon. We had these shunts in our animal hearts for months and even years, and I found that Teflon was a beautiful material from the standpoint of discouraging thrombus and platelet adherence.
And now, Bob, you have some models, or you have some actual material of these shunts of the sort that you just talked to us about. Maybe you could show those to us now.
The original shunt, which we first implanted in April 1955, was nothing more than a simple ventricular tube with side perforations near the tip and an atrial tube which had the slit valves, as I showed previously in my slides. And these were tailored to fit and connected. Then later on, we wanted to be able to flush the system, so we added what is essentially known today as a burr hole valve, which when compressed forced the fluid through the ventricular and through the cardiac or peritoneal tubes. Since, of course, this time there have been many improvements in valve design. And currently, I think there are 14 companies that are manufacturing shunt systems, but more about this later.
Now, the problem, as I understand it, with some of the shunts that you've just shown it, is what one might call an obligate shunt. That is, when you press the reservoir down, it actually forces a increment of fluid out of the ventricle into the reservoir and down the distal catheter, so that whenever that is pressed and released, there is in essence, a sucking effect on the ventricle to bring the CSF fluid, the CSF up into them, and then forces that out at the same time, the distal shunt. Now, it's fair to call it an obligate shunt, is that correct?
I would think so, yes.
And then there was a design problem early on which I recognized, and that was that when people got to the point of having had a shunt for a period of time, we found that we were getting some biopsies of the ventricle wall by that technique. And then it became clear that maybe it would be better to have a different type of design, and that design came to a non-obligate shunt in which a reservoir only was in the shunt system and had a distal valve of the slit type that you showed us on the end of it, so that if one pressed that valve, that reservoir down and let it come back up, it was simply a to and fro device, and one had to intentionally obstruct its return to the ventricle before you could check the distal end. The hope on that design was to keep from causing some of the ventricular debris to get into the shunt, go distally, and then cause some obstructions, which you're going to talk about, I guess, a little bit later. I had thought maybe now we ought to go to some of my feelings about this, and having been influenced by you back in 1956, may I give some of my thoughts about that experience?
Well, Eldon, your clinical experience is much greater than mine, and I hope that you would talk to us about that.
It's an interesting effect of having Dr. Pudenz, who's been one of my role models for a number of years, and I have a chance to talk to him in this manner because it was in 1956 that I visited Pasadena and came under the influence of his scientific approach to the treatment of hydrocephalus. Prior to that, at the University of Washington, I had become interested in hydrocephalus because of an experience with tuberculous meningitis. This was rather forced on me because I was a junior man at the University of Washington, and someone with tuberculous meningitis would become very ill. I found out they had hydrocephalus, and I began to use Dr. Nissik's approach, the ventriculomastoid shunt. On that series of patients, the results were so dramatic. I think that was one of the events in my life that made me then become very interested when Dr. Pudenz first published his ventriculoatrial shunt paper, and I visited him there, and from that point on, I've been interested in hydrocephalus and its clinical problems as they have unrolled. I've become very impressed with the problem of long-term follow-up on the persons with hydrocephalus. Hydrocephalus is a very dynamic process. It changes from year to year. And with Dr. David Shurtleff, a very effective pediatrician at the University of Washington, I studied a series of patients, gave a 5-year report, a 7-year report, and then a 13-year report on the effectiveness of treating hydrocephalus by shunting techniques, primarily the VA shunt style, which Dr. Pudenz had developed. The to and fro flushing device that I just mentioned was used in those cases, and we found in those studies that the change in the patient's clinical problems was extremely important, and one could not depend on initial studies to feel that that type of hydrocephalus was going to be the same type forever in that individual, so that it had a variability as time went on. They had an individuality with each patient as time went on. And I became very interested in what the long-term results were. I guess the philosophy was a little like, here is a piece of artifact that we're implanting in an infant, and we expect that to last for 50 to 60 years? And the answer obviously was, well, we really can't expect that. The only way we can make up for it is by having a long-term follow-up by concerned individuals, and that continuity of follow-up is extremely important, which is what we try to emphasize in those 3 papers. And I'm very obligated to Dr. David Shurtleff, the pediatrician with whom I worked at the University of Washington in that sense. The difficulties in long-term analysis has been something that I have then dwelt on since that time. I've been particularly interested in the complications of long-term shunting, the complications of initial diagnosis, and the assurance that the initial diagnosis is the correct one. I have a series of slides I'd like to now show, which possibly brings us up to date without going through a number of events which characterize my professional career so far. But I'd like to bring it up to date with our most recent approach. We have looked at the hydrocephalus patient and what does the long-term view of this hydrocephalus patient hold? What is the prognosis? Initially, our studies showed that the hydrocephalus patient, if treated properly, could have an IQ IQ profile which would be entirely normal. If complications, however, developed, the prognosis became much, much more modified. Therefore, it was important to have long-term follow-ups. At the present time, I've been trying to emphasize that long-term follow-ups will be surprising. It'll show the acquisition of other lesions in the system, such as converting a communicating hydrocephalus to an aqueduct stenosis hydrocephalus if one does a ventricular shunt. That then makes that person much more reliant on the shunt for the rest of his life. And our major effort has been to avoid lifelong shunt, because once I made a statement in a paper that once a shunt, always a shunt. That isn't quite correct, because it depends on the type of hydrocephalus and the type of shunt that's to be involved. I'd like to dwell on that in just a moment or two. But to show this particular, where we are now in this regard, I'd like to show this series of slides. Overdrainage has become a very real problem in patients whom have been followed for a period of a number of years after having been shunted. This is a ventricular shunt. Presumably, these patients that we have studied and have reviewed are due to, they have a hydrocephalus due to aqueduct stenosis. So until otherwise stated, we're talking about aqueduct stenosis hydrocephalus. Dr. Pudenz and I have just completed a review of the literature to assess the effects of overdrainage of the various types of ventricular shunts currently used by the full spread of neurosurgeons in our country. We have found that subdural hematoma does occur, that craniosynostosis and acquired synostosis does occur, that the slit ventricle syndrome appears, and that the low ICP syndrome appears at those times in their career. What is the subdural hematoma? We need to dwell very little on that. It occurs at about any age, and it actually is more common in the adults. You know, presumably that's because there's no skull collapse capability. They cannot compensate as well for a low ICP, and the subdural hematoma therefore occurs. It's often silent. It oftentimes is diagnosed because of a routine CT or MRI. Again, a very important point about long-term follow-up of the hydrocephalic patient in a continuity setting if possible. Another point, this is the type of depressed fontanelle that many neurosurgeons seek in treating a baby who has hydrocephalus aqueduct stenosis. Nevertheless, this sets up a situation ideal for the development of subdural hematoma, and from our view, this is overshunting and probably one of the first evidences that such is the case, because it also favors craniosynostosis. This occurs usually at 2 to 3 years of age when it's first recognized. It's overdepressed fontanelle, overriding of the sutures, scapholocephaly will result. It's unsightly at a teenager level, and they become very psychologically involved with their appearance. So it's important, if possible, to avoid this in 2 to 3 year old children. This is an example of the scapholocephaly that's seen. The overdrainage definition further, slit ventricle syndrome. This is not just slit ventricles or tiny ventricles on CT imaging, but there is intermittent evidence that the shunt is obstructed by the clinical history, but at the time one sees them in the office, they oftentimes have a nice functioning shunt. but it's the intermittent nature that makes it a little confusing. But the slit ventricle syndrome needs to include a clinical problem, not just an image that indicates tiny ventricles, which obviously must indicate that there has been overdrainage. In comparing that and then to the low ICP syndrome, these are incapacitating symptoms when the patient is upright. These are relieved to asymptomatic when they lie down and are supine. Nevertheless, they do have tiny or slit ventricles on the CT or MRI. They oftentimes have no evidence of obstruction. But the major point is that when they're upright in measuring the ICP, they have a normal mean and high pulse pressure when they're lying down, but when they're put up, there's a dramatic fall of the mean ICP to as much as a minus 400. That obviously brings up the question, how often does this happen? If we take all of the overdrainage syndromes which we have just described, these occur in 10 to 12% of the patients reviewed in this literature review overall. And the surprising point is that this occurs at 6.5 to 7 years after the first shunt is placed. These are statistics which we need to attend to. Some of the reasons we haven't recognized them is the fact that many of us have been unable to follow our patients as long as we would like to because the patients move around the country. Their background is not clearly defined, and some of us are not aware of how long they've been shunted or the type of shunt they've had. What are the causes of overdrainage? Some of our present shunt systems are, most of them as a matter of fact, have opening pressure valves. They are also relative pressure gradient dependent. They do not have an absolute shutoff level of pressure. And they have no control basically, therefore, when the patient is upright. The problem is that there's an effect then, an excessive, prolonged, negative IC when the patient is upright because the shunts work too well when the patient is upright. But when they're lying down and are flat, they don't have a problem because they have no excessive low ICP at that point in time. I'm covering that in just a moment. These shunts are opening pressures. If a patient coughs, strains, does something as you see here in a pressure recording, this sets off those shunts because now those shunts are based entirely on a pressure gradient effect. If the patient with a shunt is lying down, there is very little gravity effect from the level of their brain, the uppermost, to the point where they are draining it in the heart or in the peritoneal cavity, as shown here in the supine position. When that patient, on the other hand, comes into the upright position, there now is a considerable gravity effect, not only on intracranial venous volume, but on the column of fluid within the shunt itself, which then tends to suck fluid out of the brain cavities based on the distance from the point at which it drains to the top of the brain level. This occurs with a siphoning effect if the catheter in the ventricle is in the frontal area, but it's direct drainage if the catheter is in the posterior portion of the ventricle, since there's no siphoning effect to get it up and out of the skull. And this is an important point that we're trying now to emphasize, that there's a striking difference in the way the shunt functions in the supine position and in the upright position. The recommendations from this review have been that we need to have an accurate ICP record with a reference point widely accepted. We'd like to make that point as clear as we can. We'd like to re-emphasize that the supine and upright ICP ranges in the normals are known, and we need to apply that to shunt design. And we'd like, and the last, is to consider biologic treatment methods, because these actually emphasize how difficult it is to design a shunt which is going to meet all the biologic requirements of patients who have hydrocephalus, particularly long-term hydrocephalus. Therefore, if we look at a proper and accepted reference point for measuring intracranial pressure, we have to take into effect, whenever we measure an intracranial pressure, the weight of the brain above the point from which we're measuring pressure. In the supine brow-up position, there is a measure of brain weight going up to the top, to the front of to the brow. If we're doing a lateral, it goes up to the ear. If we're doing it back here, it goes to the vertex. If we're doing a spinal tap, it goes from this point where we're measuring the pressure to the top of that system. This is really just a U-tube. If we have a shunt tap, the same concept needs to be kept in mind. If we're measuring it from the patient and the brow up, this is all brain weight. There's nothing to do with increased intracranial pressure. And the same goes for the being in the vertex up or in the lateral position. Keeping in mind then that a shunt probably should have a point at which a needle can be inserted transcutaneously through the scalp into that a to and fro type reservoir, which will reflect the true intracranial pressure. And the second point is, if we accept that, we need to measure it with a technique using a device such as this, which is a transducer, which is essentially volumetric. Here's a transducer which is right in the tip of a catheter. And the correction factor, the calibration of these needs to be understood, but that's very simple, straightforward hydraulics. When we measure a patient in the supine position and place them in the upright position and see a fall of this degree and down to a minus 150, this is considerable below normal. When we correct it by one of the techniques available, we can bring them back to the point they are no longer symptomatic with this dramatic drop in pressure when they go from a supine position to an upright position. It's important then to realize that a normal pressure in the person in a supine position at this point is between 50 and 80 millimeters above the head. When they stand up, that pressure falls to a minus 50 to a minus 80 millimeters of water below the vertex. The patients I'm referring to, however, who have low ICP syndrome are overshunted with the slit ventricle syndrome as well, and those that we have seen with the low pressures when they are initially shunted with subdural hematomas, they have a fall in pressure going from a normal to a pressure that's now minus 250, and we now have measured that down as low as minus 500. Now, why does that occur, and what is the normal rate? Normal, what would we like to establish in the supine and upright positions? In a normal person who is supine, the pressures are 0 to plus 20 at this reference point that we've just described. There is no gravity effect on the intracranial contents. A normal person in the upright position, on the other hand, no shunt, he's normal, has an effect on the intracranial venous volume in which there is a gravity-induced fall in intracranial pressure because there is an exhaust of venous volume back to the heart simply by the gravitational effects. There's very little effect of this on CSF volume change because of the slow nature in which the CSF volume is extruded and the relatively rapid replacement of that. If we put a shunt in, however, we now have converted the effect by gravity, which is now effective not only on the intracranial venous volume, but also on the CSF volume because of the design of the current shunts. They are a relative value. That means if we have a reference point at this point, and we have a reference, the level that we're talking about now is zero pressure at this point, that is the zero pressure effect of this shunt because of the relative values here. If this should be, as an example, minus 200, and we have a considerable drop down to this point, so we're dealing with a minus 400 down here, we then have a pressure gradient which most of our shunts will continue to function and cause a drop in our intracranial pressure, which is well beyond normal and which is broken up only when the person reassumes a supine position. Now, someone has said, is that why we don't see the low ICP syndrome until late in life? And it may be so. Infants spend a considerable portion of their time in the supine position so that their shunts are not working anything like as much as when an adult in the upright position is earning a living. And it may be that that's why we have an average of 7 years after the initial shunt before we see these evidences of overdraining. Nevertheless, we have to keep in mind that the gravity effect on our intracranial pressure is something we tend to ignore in terms of the design of our current shunts. We might keep in mind, likewise, that if we are in a gravitational an absent gravitational area, that we do not have normal intracranial pressure. NASA is interested in this as an example as what happens in the treatment of hydrocephalus on the moon, where we have 1/6 the gravity effect. What happens in the satellites when they're in space? And there is no effect of gravity, and we do not have normal intracranial pressure. In fact, if you average the intracranial pressure on our astronauts and the cosmonauts, since we have an average of a negative intracranial pressure when we're up and about and a positive when we're lying down, this does not occur in space, and their pressure then is relative increase intracranial pressure. how can you achieve something back towards normal? If we have this graph, here is the upright, this is what the pressure falls because of the intracranial venous volume of gravity effect. Here is what our usual VA and VP shunts do. They take it down to a minus level of minus 250 to 300. We've measured it as low as minus 500. The zero pressure shunt system has been devised, which keeps this pressure up. The third ventriculostomy and Torkelson's probably also keep it up in obstructive hydrocephalus. Therefore, shouldn't we give some consideration to what technique will give us the best method of maintaining a normal intracranial pressure? If we look at a program such as this program indicates that the initial suspect of hydrocephalus with ventriculomegaly has increased ICP by one technique or another, serial MRIs, CTs, measured ICP, but we demonstrate that he has communicating hydrocephalus. His LP shunt is the advisable one for him. That is a distalmost part of his CSS system. Aqueduct stenosis, he needs to have a shunt initially to get his pressure down to where it belongs. We then feel we should measure the absorption deficit from the ventricle in cc's per hour. What does he need to get out of the ventricles? We need to look at the CSF absorption capabilities he still has. Using the Katzmann infusion test, we can measure that in cc's per hour. If these then meet, are equal, or one exceeds the other, the absorption exceeds what he needs, then one should consider that he has an intracranial operation. If we find then we are able to put a third ventriculostomy Torkelson, a fistula in place, we probably will get a higher than 50% rate that is currently available for these operations, because we have measured what he can absorb and what he needs to have absorbed, and we probably can increase that to somewhere around 85%. Of those who do not have a match of the CSF excess, CSF absorption, they need to have a permanent VA-VP shunt with the idea of keeping their pressures as close to normal in the upright and in the supine positions. This, therefore, is a program which will control ventriculomegaly. It will avoid overdrainage, and will give us a maximum opportunity, I think, to maintain as close to normal intracranial pressure in the supine position as well as upright. Now, that's about where we stand at the present time in our program in terms of a rather long study to approach the problem of design of the shunts where we need them, but also to re-emphasize the fact that we do have biologic mechanisms which probably we ought to think more about. Bob, that's more than maybe I should have been saying, but it gives to me, at least, I think I understand more about intracranial pressure and what we need in terms of shunting because of my rather protracted experience with a very complicated group of hydrocephalic patients.
Well, Eldon, I thank you for that very excellent report. I think we have attempted to more or less discuss a very difficult problem in a relatively short period of time. There are some things that have been left unsaid. We know that shunting has complications. For example, the infection rate is very worrisome. Reports in the literature indicate infection rates up to 22%, and I would encourage people who are interested in lowering their infection rate to read the reports of Maurice Chou of Marseille, who to my knowledge has the lowest infection rate that I've been able to find, namely 0.7% for primary procedure and 0.9% per revision. So much for infection, and we can talk about this for a long time. Then the question of obstruction. I've had so many questions directed at me. Bob, how much protein will valves handle? We've evaluated a large number of valves with various levels of protein and find that as long as there is no particulate matter in the cerebrospinal fluid, that valves from the manufacturers that we have evaluated can handle up to 1,500 milligrams %. So I would encourage that one think in terms of particulate matter, that is cryoglobulins, amorphous protein precipitate, fibrin, cells, and so forth, rather than talk strictly about protein. I'd like to finish my remarks by commenting on some things that I think are coming up that are very important. We now have valves, of course, that can be programmed as to rates of flow. We now have valves that have very sophisticated valve designs. We now are coming with new biomaterials for tubing that can grow. Polyurethane materials have been shown to lengthen considerably without changing their internal diameter if they are fixed at two ends. And we are also, before too long, will be having various chips incorporated in shunt systems which will measure pressure and flow, which will actually determine certain of the chemical constituents in cerebrospinal fluid. And I foresee that while we still have many headaches, many problems with treating hydrocephalus, that there's no question we're getting better all the time.
If we still have some time, Bob, I'd like to bring up another point.
Okay.
One of the problems that we find, at least in my experience, is a difficult, is a realization which seems to be difficult for us in our own environment. Often this environment is foisted on us, in which pediatric neurosurgeons are unable to follow patients whom they have shunted as infants long enough to really have the length of follow-up and the continuity of care that I would like to see. I've been interested in hydrocephalus not only in the infant where the initial diagnosis may be made, but in the adult who has an acquired hydrocephalus. And I find that the same exact phenomena occur in the adult that occurs in the infant. The phenomena are modified in the infant from what is present in the adult. And a problem that I see frequently is the difficulty in having a complete initial diagnosis. In the infant, the diagnosis of a communicating hydrocephalus and an obstructive hydrocephalus, that means an aqueduct stenosis, is maybe a little easier, and yet it isn't often done. The same I find in adult hydrocephalus, that a patient will be operated on with a ventricular shunt when they have a communicating hydrocephalus. And I see this also occurring in infants, that a ventricular shunt is done when an LP shunt might be more appropriate. In my experience, an LP shunt for communicating hydrocephalus in children and infants, I've had, if I follow those patients a period of 4 to 5 years, about a 12% incidence in which the hydrocephalus will come to an arrest phase and the LP shunt can be removed. Now that's been reported, but I also find that in the adults, we have patients who are suffering from what is decided as a ventriculomegaly. The diagnosis is not carried to the point of deciding that it's a communicating hydrocephalus. A ventricular shunt is put in place, and the patient goes through this tremendous problem of overdrainage. An LP shunt done with communicating hydrocephalus has a much better probability of not having overdrainage problems and not obstructing. And there are two reasons for this. The first is that the spinal fluid in the lumbar area is quite different from the spinal fluid in the ventricular system. There's an absence of debris. Dr. Pudenz has already alluded to the fact that obstructions in ventricular shunts oftentimes occur because of debris. Now, debris in the ventricular system occurs because of the sloughing of the ependymal cells, the problem of the ventricles enlarging and then constricting again with debris, some of it just gliotic material, getting into the spinal fluid, and then that material gets into the shunt. Some of it can go through the shunt, much of it can't, and it tends to plug it off. However, that material is not in the lumbar subarachnoid space, so one can use very small tubes. These small tubes themselves restrict flow to a point that's much more physiologic, and one doesn't even have to put in valves in the lumboperitoneal shunt. Just have a long enough piece of this small diameter tubing which has an increased resistance compared to the size of the tubing we need in the ventricular shunts, And the result is we have control of the increased intracranial pressure. There isn't an overdrainage, and there is a better chance of having an arrested hydrocephalus permanently from that type of shunt than there is from the ventricular shunts. Now that isn't true in the adult, but it certainly is true in the infant. So that the lumboperitoneal shunt is a very simple type of shunt. It's probably not used as much as we ought to use it. It has a good physiologic basis for using it more than we do, because I think we can prevent complications very much more. What I had said previously about ventricular shunts does not apply to the lumboperitoneal shunt. Bob, we've covered a great deal of territory in discussing the hydrocephalus. There are many other things that have come up. I would like to have talked a little bit about what does the pulse pressure in the CSF mean. Some of the slides I showed that the pulse, ICP as an example, gets very high when you get low pressure. It's also very high when you have a high pressure, and it goes through a parabolic curve at the normal mean pressure. And it has a lot to do with brain function. That's something that has yet to be explored more completely. I think the intracranial approach by the new techniques for plexectomies or for third ventriculostomy from inside the ventricles, an example. It's a very exciting area that's developing and needs a lot of our support. I'm sure you have some further ideas.
No, Eldon, I would like to wind this up and sum it up by saying how grateful I am that you give us your clinical experience. My clinical experience in hydrocephalus shunting is quite limited, even though I try to keep up on all the recent developments. My research interests in recent years have varied considerably, although I still am looking forward to the day when we have a real wonderful way of handling hydrocephalus.
Maybe the best thing is to prevent it, but the doggone, I really don't know how to prevent hydrocephalus.
Anyway.
It's been a real pleasure, Bob.
Yeah,
Thank
thanks
you very
a lot.
much. You always
Thank
help
you.
every time I talk with you.
Good.